And these are emergencies that will affect these are emergencies that are especially related to female and their reproductive system. So females are uniquely formed for the purpose of conceiving and giving birth. Therefore, you're gonna have some emergencies because of that uniqueness, which are specifically related to female, and that's where we have gynecology. So gynecologic emergencies will be those emergencies specifically related to those situations. And that's why it's also important as healthcare providers, when you go on a scene during your general impression, we should always try to identify if we are dealing with a male or a female, because you're going to have some questions that you're going to be asking of female, which you're not going to be asking of a man. So it's, again, nowadays sometimes we have it hard sometimes to differentiate, but it's something that we will need to know as you go into your assessment. So occasionally girls and women in their childbearing years will have major gynecologic problems requiring urgent care. And that's where we'll be called when they're having these issues. And these can be cases where you have excessive bleeding, soft tissue injuries, sexually transmitted diseases, and vaginal disease. Again, we say females are uniquely formed because of that reason for them to conceive and give birth. So they are going to have their reproductive system, which is likely to have these issues. And we need to recognize what's happening and be able to provide the appropriate care as AEMTs to your level. So when you look at the anatomy and physiology of the female reproductive system, this is how it is structured. So you have ovaries, 2 ovaries on either side of the lower abdomen. And these ovaries are able to produce ovum, and these are the female eggs, and also they produce hormones, estrogen and progesterone. When we did the endocrine system, we looked at the pituitary gland, which is the master gland, release hormones that control other glands. And one of the hormones we looked at was follicle stimulating hormone, FSH, which and also the luteinizing hormones. These help in the reproductive system, and that is the hormones that will trigger the ovaries to produce these other hormones. But when you look at the anatomy, we recognize that you have the ovaries, which we say will be sitting there at either side of the lower abdomen, and then you have the fallopian tubes or uterine tubes, which are connected to the ovaries and to the uterus. So the fallopian tubes links the ovaries with the uterus, and then the uterus is the muscular organ which supports the developing fetus. And then the next area you have is the cervix, which is the lower end of the uterus, the narrow end of the uterus, and then that leads into the vagina, and then that leads to the outside where you have the external genitalia. So here you have the front view and you have the side view. So you have to have an idea of the structures and how they are situated, and you can have an idea when problems and issues developing. So the fallopian tubes are the ducts that extend from the uterus and terminate near the ovary on each side, and they carry an ovum from the ovary to the uterus. So every alternating months, you have an ovary will produce an egg or ovum, and it travels via the fallopian tube to the uterus. And if it's fertilized, implantation on the wall of the uterus, and it's developed. If it's not fertilized, then it will be shed in the menstruation cycle. So the uterus or the womb is that muscular organ where the fertilized egg implants and grows, and it's responsible for the contractions during labor. So it's very important, and that's the basic structure. You have the vagina, which is the lower part of the birth canal, and it's the outermost cavity of the female reproductive system. It completes the passageway from the uterus to the outside world for delivering the infant. And the cervical canal is the passageway from the uterus to the opening into the vagina. So that's the cervix during the birthing process will have to be dilated to a certain dimension to allow the passage of the fetal head. And when we look at the external female genitalia, this is the presentation of it, and this is the area that is exposed, and it's prone to injury, and you have the different dimension of it. What you must recognize is that it's very vascular and innervated with nerves ending, so it can be painful when there is injury, and it can cause some amount of bleeding. Usually not gonna be life-threatening, but you can have bleeding from these highly vascular structure. So just recognize the different area. Point to note is between the vagina and the anus, you have a area of tissue that's called the perineum. That's important to note when there's delivery of the fetus. It will cause stretching and tearing, and sometimes they actually make an incision in it to prevent it from tearing, and they will massage it or help in the delivery of the fetal head. And also you have the urethral opening. Again, when we come on to the infections, they are gonna be coming from the vagina. Most infections are gonna be picked up from the vagina and travel up, as we saw, the cervical canal into the uterus, and it progresses all the way up to the fallopian tube and go to the ovary. So recognize that the external genitalia is there, where that's the part that's exposed, and most infection will start from there. So as we continue to look at the anatomy and physiology, each month the level of hormones rises and certain characteristic changes take place. And we said that the hormones are triggered from the pituitary gland by those follicle stimulating hormone along with the luteinizing hormones, and this trigger the ovaries to produce these other hormones that will give rise to the different changes. So it allows the ovulation to take place. It allows the uterus to build up in preparation for the implantation of the ovum, or the developing the fetus for the implantation of the egg, and also the shedding of the lining if no implantation takes place. So each month the level of hormones rises and certain characteristic changes will take place. And out of that, you will have menstruation. So what is menstruation? This is the cyclic shedding of the uterine lining that occurs approximately every 28 days. So once the ovum is produced, it's gonna travel along the fallopian tube and decide that it was whichever ovary produces it, and it will travel to the uterus, and the uterus would have been prepared for the implantation, and so the walls would have been thickened, and it's implanted. And if after 14 days no fertilization occurs, then that lining will be shed, and that is what is the menstruation, that shedding of the lining. And the first menstruation to occur, the onset of menstruation, the first one to occur, they call that stage menarche, or menarche. So that's the first menstrual period, and it normally happens during puberty. So rough age group, they have it as 11, between 11 to 16. You'll have this onset of menstruation. Again, sometimes you'll get called to these cases where the mother noticed the child, and they might believe it's something life-threatening and might call you to that scene, and you have to be, most time in these cases, you have to try to educate them and be supportive, don't be judgmental, but again, you have to do your assessment and encourage them. Sometimes you might have to take in that child with them to the hospital to sort of, let them feel a little better. But that's the menstruation. And also the last menstruation to occur, the cessation of menstruation, the ending of menstruation, is menopause. You have also what you call a condition can occur where menstruation stop for a period. That's amenorrhea. That's not different from menopause. But menopause is when you have the last menstrual cycle to occur, and basically that is signaling that all ovarian function has stopped. So after menopause, it's cessation of ovarian function, but you can have cessation of menstruation leading up to menopause, but person can still become pregnant. And so you will have some patient, you will have become pregnant, and they are in denial. They don't realize that they are pregnant because they feel that they were in their menopause and ovarian function has ceased, but it wasn't a true menopause. So what you can have premenstrual syndrome, and this is a syndrome where you have some symptoms occurring leading up to the actual menstrual flow, and it will varies for persons to persons, so it will affect persons differently, but it normally subsides once the flow begins. So once the menstruation start, the symptoms will subside, and they will come with pain, weakness, lower back pain, and this can be affected by stress, diet, alcohol consumption, and prescription or non-prescription drugs use may exacerbate this premenstrual syndrome. Pre-hospital treatment is predominantly supportive. So you will get called to these persons having these symptoms, and the main thing will be the pain, and it's basically supportive because it's just part of the process. But again, they might not realize it, and so they will consider that it's something serious happening to them, and they will call you to respond. So again, it's supportive care. You're always going to be concerned about the ABCs. First, don't just be judgmental and say nothing is happening, but always do your assessment. But at the end of the day, most of the time, it's just supportive care. You also have a thing that they call mismerge. This is some abdominal pain. They can come with cramping, and this occur 2 weeks before the beginning of menses. Again, it's result of the ovulation process. So what we must recognize is that the ovaries, there's not an opening for the egg to leave the ovary, so it is actually leaving through the walls. So once it's leaving, it can cause that pain, and also the whole process of the contraction to move that egg along in the fallopian tube, they will have these pain and cramps, and they will consider it as a serious issue again, and you might get calls to those cases. But recognize that it's part of the process. It's all about what's happening in that ovulation process. So signs and symptoms include sharp cramping pain in the lower abdomen, often localized to one side. So it's localized to one side because it's one egg, each ovary produce an egg, and so if it's coming from the left side, that left ovary is producing that egg for that month, then the pain will be localized to that side. I mentioned this before, amenorrhea. It is when you have absence or cessation of menses. It is different from menopause. So amenorrhea is the absence or cessation of menses. It can occur with young persons, old persons. It can occur in persons who are very athletic. It can occur because of emotion or stress. So it is not menopause. It is just an absent or cessation of menses, and after the stress or emotional problems clear up, or the person is not athletic anymore, then they will have their menses return. So you have to recognize that. And again, some persons will see it as a problem, and they might call you to respond. They are not having their issues. So be mindful that these are conditions that can happen. And again, persons might have this absence and believe it's menopause, and then they become pregnant and they are having the signs of it, and they are in denial because they were so sure that they were in menopause. And again, these are cases that you will be called to. So don't be judgmental, just reassure them. And again, you might just have to provide supportive care. So once you understand the anatomy and physiology of the reproductive system, and we're focusing on the female reproductive system, then you need to recognize that there can be problems. So what are the problems that can occur with these with the reproductive system, which can lead us to be called to these emergencies? So you can have acute or chronic infection. So basically, that's the simple case. So a person can have, we have a lot of infections, STI, STD, sexually transmitted diseases. And I mentioned before that the external genitalia, that's what it is, exposed, or the external area, the vagina, which will cause an infections to be picked up from there, and it's gonna pass right up along the tract or the passage all the way up, can potentially go to the ovaries. So you can have acute or chronic infection. You can have hemorrhage. Different types of things will cause bleeding. You can have rupture of a cyst. A cyst can form on the ovary and it can rupture. You can have rupture of an ectopic pregnancy, and this is where you have ectopic pregnancies, when you have the egg being developed in an area outside of the uterus. The only area the egg is supposed to develop in is the uterus. That's the organ that is designed for it. Anywhere outside of that will cause a problem, and it can rupture. And that is the ectopic pregnancy once it's developing outside of the uterus. So these are the emergencies, the problems that can go, issues that can have with the female reproductive system that you as an advanced EMT will be called to. And so you have to recognize what's possibly happening. But at the end of the day is what you are presented with, you will be treating. Also, you can have what we call acute or chronic infection of the upper female reproductive organs, which is in the form of pelvic inflammatory disease. This is where you have the upper aspect of the female reproductive system infected, and it's likely from the uterus to the fallopian tubes to the ovaries and even the surrounding areas. So that area will be infected, it will become inflamed, and the patient will have chief complaint pelvic pain and fever. Also, they can lead to sepsis, abscess formation, generalized peritonitis, and infertility. So again, the pelvic inflammatory disease is gonna be caused most of the time from an infection that started in the vagina. So all of those sexually transmitted diseases can progress to the uterus and all the way up to the ovaries and can lead to pelvic inflammatory disease. And again, we say it can lead to infertility. It can affect the ability of the uterus to be implanted with the egg. It can affect the functioning of the ovary. It can affect the fallopian tube. So it can affect, the person can become infertile. So it's a significant, it's not usually life-threatening, but it can, again, we say it can lead to pelvic inflammatory disease, can lead to the ectopic pregnancy, because if the uterus is damaged, the fallopian tube damaged, then especially uterus being damaged, it can affect the implantation of the egg, and so it will develop outside of the uterus. So PID can lead to ectopic pregnancy. So when we look at the milder issues, sexually transmitted diseases, they are milder, but as I said, they can lead to the severe cases that you'll be called to. So sexually transmitted diseases, you have treatment of a patient with an STD related emergency typically involve placing the patient in a position of comfort and providing supportive care. So these emergencies are not usually life-threatening, but they will call you because they are having this discharge, abnormal discharge. They will have burning, similar discharge, and so they will call you to say that they're having an issue, and so it's gonna be supportive care. Again, don't be tunnel vision and just say, well, it's simple. Assess the patient as you normally would, without any problem with their ABCs, and then you will just provide that supportive care. So you can have it in the form of bacterial vaginosis. In this case, the normal bacteria in the vagina are replaced by an overgrowth of other bacteria. So there are bacteria there that provide a useful function in the vagina, but when they are overgrown and they are replaced by other bacteria that take charge and they become problematic, then it will give rise to these symptoms where they have itching, burning, or pain, and maybe accompanied by smelly discharge. Again, we say not life-threatening by themselves, but they can progress to becoming infection up the track and lead to pelvic inflammatory disease and can go to cause ectopic pregnancy. So they need to be treated. Another one is chancroid, which is caused by infection by the bacterium Haemophilus ducreae. It causes painful sores, ulcers, usually of the genitals. So this is almost similar to syphilis or gonorrhea. Another form of STD is chlamydia, and is reported to be one of the popular ones, caused by the bacterium Chlamydia trachomonas, and its symptoms are usually mild or absent. Again, we say by themselves they are not life-threatening, but again, if not treated, they can progress up the track and cause significant life-threatening issues potentially. Another one of the sexual transmitted diseases, cytomegalovirus, CMV, is a member of the herpes virus family, and so its common viral infection has no known cure, and this is where it can cause prolonged high fever, chills, headache, malaise, extreme fatigue, enlarged spleen. So again, by itself, not life-threatening, but potentially can be. And again, we say it can cause other problems in the tract. Genital herpes, infection of the genitals, buttocks, or anal area caused by the herpes simplex virus type 1 or type 2. Again, this can have implications. Gonorrhea is another sexually transmitted disease. It's caused by the Neisseria gonorrhea. Can also grow in the mouth, throat, ear, eyes, and anus. All depends on which part of the orifice is affected. If the infection is not treated, the bacterium may enter the bloodstream and spread to other parts of the body, known as disseminated gonorrhea. So that's the life-threatening aspect of it. When it's gonna be systemic, it's gonna go into the bloodstream, and that can be severe case. We can also have genital warts caused by human papilloma virus, HPV, and it's one of the most common STD. Some infected people have no symptoms. If the virus is passed to the fetus, then they can have laryngeal papillomatosis, and that can develop. So they will get the virus during the fetal stage, and that can give rise to the laryngeal papillomatosis. Syphilis is another serious sexually transmitted disease caused by the bacterium Treponema pallidum. Signs and symptoms mimic other diseases, and a person with syphilis may remain asymptomatic for years, and that's where it's in the latent stage. So they are saying that they said 3, but it's actually 4. So you have the latent stage. Latent stage is one of the stage, but in the early stage, which is the primary stage, the stages is all about the presentation of it. So in the early stage, the person will have a single sore or ulcer on the affected site, the penis, the mouth, the vagina, the anus. And so it's that early stage. After 21 days, roughly, they will present with this single sore. It's non-itching and firm. And also after that 21 days, it will progress to the secondary stage, where it start to form rash, diffuse rash. So you have rash all over the body. And after that stage, you'll come to the latent stage, where there is no more symptoms, there is no more signs. But if you test that person, they will be tested positive for that bacterium. And that stage can last for years. That they say can go 10 years, and you're no more symptoms. You're asymptomatic, but you still have that bacteria in your body. And at the last stage now is when it start to affect the other body systems. It can affect your neurological response to it. Now it affect your cardiovascular system, and that's the tertiary stage. That's the last stage of it. So it's all about the stages that it goes through, but recognize that the person with syphilis may remain asymptomatic for years. Trichomonasis is another sexually transmitted disease, and it's caused by the Trichomonas vaginalis, transmitted through sexual contact. And its symptoms are frothy, or they will say thin vaginal discharge with strong odor, and it comes with irritation and itching of the female genital area. The person will have this urea, that's difficulty when they pass their urine, and they can have lower abdominal pain. So all of these are diseases that can be transmitted sexually. And as I said, the main complication is that they may not be life-threatening, but they can lead to other severe conditions. And as it relates to the Trichomonasis, if left untreated, can lead to low birth weight or premature birth in pregnant women, or increased susceptibility to HIV infection. So again, it has serious complications or implications. We also have vaginal yeast infections. So typically caused by the Candida albicans fungus. If the vagina becomes less acidic, the yeast population may increase dramatically and result in infection. So again, we say they have their use, but they can become problematic. So if the vagina becomes less acidic, then the yeast population may increase dramatically and result in infection. So the yeast have a purpose, but when they get too much, they can cause problem. So symptoms include itching, burning, soreness in the vagina and around the vulva, and vulvar swelling. So again, you might be called to cases of that nature. Again, we say it's mainly gonna be supportive care and take them in to get treatment so it can prevent that situation from remaining and lead to, we say it can lead to pelvic inflammatory disease. It can complications of ectopic pregnancy. Another complications with the reproductive system is that you can have ruptured ovarian cysts. So a cyst form on the ovary and it can rupture. That can spill content in that area and lead to inflammation. So an ovarian cyst is a fluid-filled sac attached to the ovary, can contain an enormous amount of fluid, may need surgical removal. Internal bleeding is a rare complication. So again, it's a case that you might be called to. The big one is ectopic pregnancy. As we said, the uterus is where the egg is designed to be implanted and developed. So once you have a pregnancy develop outside the uterus, and most time it's occurring in the fallopian tube, then this is an ectopic pregnancy. The fallopian tube is not designed to take a developing fetus. It is not designed to expand to a fetus. It doesn't have muscular wall as the uterus does, which is designed for that. So once that fetus start to grow, it's gonna cause that fallopian tube to stretch, and it's gonna stretch to a point where it cannot accommodate it anymore, and it will rupture. So that's the danger with ectopic pregnancy. So vaginal bleeding may be the only sign, and so you will have bleeding occurring at a time when it's not there. Even the normal menstruation would not be occurring. So once you have bleeding, vaginal bleeding normally occurs in the early stage of a pregnancy, then you have to suspect that it's either a miscarriage or it could be ectopic pregnancy. It's gonna be leading cause of maternal death during the first trimester as internal hemorrhage into the abdomen following rupture of an ectopic pregnancy. So this is a true life-threatening emergency. Again, you can be called to these cases. Again, do your patient assessment, manage the ABCs, recognize it's life-threatening, package the patient appropriately, and take them in. There's not much you can do if you're an advanced, so you need to establish IV access. You need to get that fluid resuscitation going to maintain the systolic blood pressure, 90 millimeters of mercury and above. But they need definitive care. A major complication of the ectopic pregnancy, so it causes that if affect the normal pathway of the ovum, include previous surgical adhesion, PID, tubal ligation, intrauterine devices. So these conditions will give rise to ectopic pregnancy. So if they had previous surgical adhesions, they would affect the ability of the uterus to allow that egg to be implanted, and so it's gonna find somewhere else to implant. If they had PID, again, that cause damage to the uterus, can cause damage to the uterus and the ability of it to accommodate that egg, and also it can have affect the tube, so it cannot come further. So wherever it is, it's gonna stop there, and therefore it's gonna start to develop where it stopped. Again, with tubal ligation is removal or tying off of the tube. Again, if that occurs, then the person egg release and it is gonna develop wherever it stopped. If you have intrauterine device, this is a device that is implanted in the uterus as a birth control measure to prevent the egg from being implanted. So if an egg is released and it's fertilized, it cannot implant there anymore. It's gonna end up implanted in the fallopian tube or wherever it possibly can. And that's the cause of the leading to the ectopic pregnancy. Now, if an ectopic pregnancy is not caught in time, the fallopian tube will rupture, and this is a true life-threatening emergency. As we said, the fallopian tube will only be able to accommodate the developing fetus to a certain point. After that, it's gonna rupture. So it's a true emergency. You have to treat that patient aggressively and remember that you need to move from that scene with that person as quick as possible, because they need to get definitive care to save them. You can have vaginal bleeding, and it can be as simple as a normal menstrual cycle, can be as extreme as a ruptured uterus. So you'll be called to a scene where they have vaginal bleeding. They might be even having their normal menstrual cycle. Again, might be occurring for the first time. They don't know what's happening, and they call you. Or it can be a case where it's prolonged, and you're called to that scene. Again, do your assessment and take it from there, but don't just be judgmental and write it off as being simple. It can be an extreme case where you have the rupture of the uterus. Any vaginal bleeding during the third trimester of pregnancy is a serious emergency, and you will look at that when you come to obstetrical emergencies. So it can be from a placenta abruptio or previa. So it can be there's a covering of the cervix and give rise to bleeding, and you can have premature separation of the placenta that can give rise to bleeding, and that normally occur in the third trimester. But we said bleeding in the first trimester, think that it's ectopic pregnancy. Color differences can be difficult to discern in pre-hospital setting. So again, it's not really up to you as the AEMT to try to differentiate what type of bleeding it is, but treat what is presented. They're having a bleeding, you control it as best as you can. Remember, we're not gonna pack anything in the vagina. Just use sanitary pads to use a diaper type dressing to control the bleeding, and note the amount of soaked napkin, and provide the supportive care and get them into the definitive care. So vaginal bleeding continue. Causes of vaginal bleeding can be from onset of labor, ruptured ectopic pregnancy, PID and other infections, trauma, lesions from previous surgery, or disease processes. So several things can be causing this vaginal bleeding. Again, we say just treat what they are presented. They're having a bleeding, you can get the history where possible, but it's to treat whatever is possible. If the bleeding is severe, you control it to the point that you can and provide that supportive care. Endometriosis, this is where you have the inflammation or irritation of the endometrium, most commonly caused by an infection, frequently by an STD. So again, the infection starts from lower, the external genitalia, and it will move up the passage. It goes to the uterus, and the endometrium is the inner lining of the uterus, and it can become inflamed and are irritated, and it can be treated with antibiotics. But if left untreated, endometritis may lead to septic shock or cause spontaneous abortion in a pregnant patient because the walls are damaged, they are inflamed, they will not be able to carry out their normal function, and it can give rise to abortion. They can have that miscarriage and lead to septic shock. So again, by itself, not life-threatening, but can have life-threatening implications. So there is endometritis and there is metriosis. So this one is where you have a part of or a type of endometrial tissue growing outside of the uterus. So the endometrium is the inner lining of the uterus, but a form of tissue of its nature can grow outside of the uterus, and that is what is endometriosis. So it's extremely painful, yet some women may not have any symptoms. And one of the leading causes of infertility in women. So it's going to affect the ability of the function of the reproductive system. And so it can cause the female to become infertile. Most common complaint is pain generally localized in the lower back, pelvic, and abdominal regions. Postpartum eclampsia. This is another complication with females. They can have hypertension and seizure after birth. It can also occur during the pregnancy. They can have it, but we are talking about postpartum, meaning it's occurring after. So after a baby is born, the mother is at risk for eclampsia for several weeks after the birth. Seizures and hypertension in women who recently delivered a baby is a sign of postpartum eclampsia. A thorough history is important to determine if the seizure could be caused by postpartum eclampsia. So when you do your history, you'll find out if they used to have this seizure before they were pregnant or they started having it after they become pregnant. So you can lean on that side. But again, it's not to differentiate, treat the patient as they are presented. So they are presented with that hypertensive emergency, they're having seizure, treat them accordingly. Again, recognize that it can be out of your scope, that you will have to call for a paramedic backup, and you always gonna make that call from early. As soon as you recognize it, even from your scene size up, from you get that call, you suspect that it's possibly can lead to things out of your control, then you call for that backup. Again, it's what is available in your jurisdiction and following your protocols. Another complication we can have with the female reproductive system as a gynecological emergencies, sexual assault cases. Most victims are women, but nowadays we find that even men and children are being victimized or sexually assaulted, and so we have to be mindful of that. We know about the recent case where you had children being abducted and raped. Provide compassion and transport to the emergency department. Some patients will have multiple system trauma. Treatment for shock may be needed. Again, treat what is presented to you. ABCs, supportive care. So we have the initial care of their physical needs, and then we have to provide that psychological care. Most of the time, these patients will need that psychological support, and we have to be mindful of that. Don't be judgmental. We are to be patient advocates. So as AEMTs, you are to be an advocate for your patient at all times. Don't be judgmental, be empathic, and where possible, and provide that supportive care. So when we're looking at patient having these gynecological emergencies, it's about patient assessment in general, again, we say is always going to be patient assessment. But as we are looking at gynecological emergencies, be reminded that you have to get proper, accurate, detailed assessment and documentation, because most of these cases, or some of these cases, can become a criminal matter. You will have to be called to go to court, and your documentation is going to come into scrutiny. And it's very important that you make sure you document exactly as it is. Obtaining an accurate and detailed assessment is critical when dealing with gynecologic emergencies issues. A thorough patient assessment will help determine how sick the patient is, whether life-saving measures should be initiated. A lot of times is what the patient will tell you that will guide you, and also, what your information you can gather. So again, most of the cases will be supportive, but you have to get that information and treat accordingly. But patient assessment will always be patient assessment. You start with your scene size up. Again, these cases can be have implications for safety of you, the AEMT. We can have seen where assault cases, the perpetrator can be there still, and you enter that scene. Be mindful that you can be compromising yourself. So always have that red flags. If you have a safety concern, most of the time we try to, police might be on scene. If they're not there and you think there's need for them, get them on scene, call for them before you go and compromise yourself. So gynecologic emergencies can also involve large amount of blood and body fluids. So be mindful of your standard precaution, your gloves, your mask, your gown, your eyewear if needs be. All information you obtain will contribute to your assessment of the patient's overall health and safety of the scene. So it's always going to be scene safety first. Once you establish a scene is safe, then you move to your mechanism of injury, nature of illness. Again, gynecological emergencies can have trauma-related aspect to it. So you might have to think about spinal motion restriction. Think about that. You want to identify that you have taken your standard precaution, maximizing on what you need to, and you need to have an idea of how many patients. And then finally, before you leave scene size up, ensure that you have called for whatever help you think you need. So again, we say in advance, you might have potential cases outside of your scope, so call for paramedic backup if they are available in your jurisdiction. You go straight to your primary assessment, and this is where you will ensure that you take your general impression, form your general impression. Very important. You need to look at your patient, have an idea. The patient appears stable and stable. It can give you an idea how you're going to proceed with your assessment. You need to ensure that you check the patient's level of consciousness with or without your manual stabilization if you're suspecting trauma. And you're going to move to your A, B, C, D, E. Again, if there's exsanguinating bleeding, you're going to move to your X, A, B, C, D, E. If patient has a weak or rapid pulse or has pale, cool, or diaphoretic skin, place the patient in a supine position. So airway management gonna be always first. Ensure that the airway is patent. If the patient has signs of fluid in the airway, you need to suction. You need to check their breathing, ensure if they need ventilator support, you give it. If they need to be supplemental oxygen, you administer it. Again, O2 sat within 94 to 98%, and also your cardiac monitor attached. You need to get your capnography entitled CO2. You need to possible rhythm issue might be present, and so you need to get your reading. You need to check the patient's pulse, rate, strength, rhythm, skin, color, temperature, moisture, capillary fill, and with signs of altered mental status, you need to get your GMR reading. Cover the patient to keep her warm and provide rapid transport to the emergency department. These are your basic things you have to do in your primary assessment. If there's signs of hypoperfusion, you need to establish your IV access and give fluid resuscitation, ensuring that you're getting your at least 90 systolic and above, but be careful not to overload the patient. So monitor their lung sounds. Once you have completed your primary assessment, which is to find and treat those immediate and potential life threats, you would have gotten your patient GCS, you would have decided on whether you need to do a rapid scan or not, and you need to decide on the priority of your patient. Is this a load and go, or you can stay and continue your assessment unseen? Then you would go to your history taking. Again, we say conscious patient, you want to get that history as quick as possible because the condition can change. And also you work with your resources that you have on hand. You have additional persons can start your secondary while you are getting the history, but you need to get that history, especially we said from that conscious patient. An unconscious patient, you still can get some form of history. Family members or bystanders are from medical alert tag or card. But for the history, you're gonna always start with your chief complaint. And again, you have this acronym OPQRST you can use to help you guide you through that process, but you need to ask the questions relating to that chief complaint and be sensitive to the patient's feeling. Again, we say you must not be judgmental. Ensure that patient's privacy and dignity are protected. And some patients, you know, especially the younger population, might not want to tell you things in front of others. So you have to give them that space if you want to get information from them. And gynecologic emergencies often have the same signs and symptoms as emergencies involving other abdominal organs. Remember, it's in that space, so it can be coming from other things. So again, don't have a tunnel vision and just think one way. Do have an open mind and do your assessment and let it take you where it takes you and you follow accordingly. That is why you have to do a thorough assessment. Assess the patient carefully to determine the nature and extent of the problem. Ask the patient about previous episodes and how they were managed, and it can give you an idea of how you will have to proceed with what's happening now. As we continue with the history taking, you need to determine whether the patient had a history of gynecologic problems. Again, we say initial problems can lead to newer problems. Inquire about the use of contraceptives, which we say can affect what's happening to them now and can also lead to other things. Consider the possibility of pregnancy in any woman of childbearing age, even if contraception has been used. We say that's a very critical thing. Every female patient that is of childbearing age, once you go to that scene, always consider that it's possible that they are pregnant and you need to ask the relevant questions. And again, we say you have to be able to identify the gender, because if you have a patient and you assume that it's a man, then you're not going to be asking those questions that you should be asking if you are dealing with a female. So again, we have to have that idea. Address any trauma. So don't be tunnel vision. Once the trauma is possible, deal with it accordingly. Once you have completed history taking, then we go to your secondary assessment. And as we said, if you have team available, once the lead person is doing your history, then you could have asked your partner to start that secondary assessment. And this secondary assessment most of the time would have been started even from the primary assessment when you'd have done your rapid scan if it was indicated. But once you are in your secondary assessment, it's going to be focusing on the area of concern and the areas that are systems of the body that are affected, and we are dealing with gynecological emergencies. So it's going to be affecting the reproductive system and the supporting systems. But if you need time allow and you have the need to, you can do a focus or detailed assessment. So this secondary assessment may be performed unseen en route to the emergency department, or in some instances, not at all. So it depends on the case that you are dealing with. If you have the patient who is having life-threatening situation and you are focusing on them, you might not have time to go and do any focus or even detailed physical examination. And sometimes the transport time is short, so by the time you complete your ABCs, you're almost at the receiving facility. But if you have to do your physical examination, you're going to approach the patient with a comforting attitude. Remember now, patients with these gynecological emergencies, even with bleeding, you would not necessarily have to physically examine the vagina. If it's having bleeding and you need to address the bleeding, then you do so. And remember, if possible, allow a female AEMT to address that issue. If not, you can ask the patient if they have a female friend that they want to be there, or you can ask for a female police to be there. Remember, we say have that comforting attitude, respect that patient, maintain the privacy, focus on the NOI and the patient's chief complaint. So that's what you're gonna do in your secondary assessment. If you need to examine, if not, you just provide that supportive care, but a part of your secondary assessment is to get your vital signs. So you're gonna get your vital signs, and you know the range of vital signs. You're gonna use your monitoring devices. You need to get your are you hearing me? Are you still hearing me?
Yes, sir.
Yes, sir.
Okay, thank you. A part of the secondary assessment is to get your vital signs, very important, and that's your LOC, pupillary reaction, your respiratory rate, depth, regularity, your pulse rate, strength, and rhythm, your blood pressure, your skin condition, color, temperature, moisture, cap refill, and if indicated, your GMR. All these vital signs you need to get, and once the patient is having signs of tachycardia and respiratory changes, this may signal signs of shock, and again, you need to treat them accordingly. Note color and amount of bleeding or discharge. Again, we say if most time the patient would have started that process of controlling the bleeding with their sanitary napkin. All you need to do is just continue using those and note whatever amount they had used before. Possibly you're gonna package them to take them in with you. Again, the receiving facility personnel will use those in their assessment and further treatment of the patient. Also, use your monitoring devices if available. So at this stage, as an advance, you should be having your pulse oximetry. Important that you have your cardiac monitor attached. Get your capnography, entitled CO2 reading, and also you're getting your reading of the rhythm. And if you need to having issues, then you need to send those into the receiving facility. But it's very important that you consider using non-invasive blood pressure monitoring to continuously track patients' blood pressure. And the first blood pressure by right, you should be getting it to your manual BP machine. So all of this must be done for your patient in your secondary assessment, your physical assessment, physical examination, and your vital signs. Once you have completed your patient assessment to this stage, and generally it's going to be for all patient population, but we are focusing on gynecological emergencies. You have done your scene size up, you have done your primary assessment or survey, you have done your history taking and your secondary assessment, then it's down to your reassessment. So you're not going to be traveling in that ambulance, going to the receiving facility, and you're relaxing, sleeping, and not paying attention to your patient. Once your patient is critical and stable, then you must reassess every 5 minutes. If the patient is stable, then you're going to be reassessing every 50 minutes. What are you going to reassess? It's all about going back over what you had started. So you had done primary assessment. You're going to go back to your primary assessment. Get back to check by the LOC of the patient. Check back A, B, C, D, E. Check back on the chief complaint. Check back on the vital signs. Any intervention you have done, you must look back at them. Are they still working? You were giving oxygen. Don't assume that the tank is still full with oxygen or oxygen is still there. You have to look and ensure that it's still flowing. You have to ensure that bleeding still check. Check back any new problem you identify, you address them. If you need to change something, you change it. It is checking the training of your patient as you go along. So treat for hypotension, for vaginal bleeding, treat for hypotension, and that's keeping the patient warm, giving them oxygen supine position. If no trauma, you need to give them that shock position. Provide supplemental oxygen even if she is not experiencing difficulty breathing. So the treatment for shock, even if they are not having breathing difficulty, we know that the cardiovascular system is collapsing. That's what happens in shock. So they are gonna need oxygen. So you administer it again. We say titrate it to your 94 to 98% saturation. Transport promptly to the nearest appropriate receiving facility. And that's very important. You need to take them to somewhere that they can get the help that they need. Reassessment continues. En route to hospital, recheck your primary interventions. We said that already. And very important, you need to communicate. So once you have gotten the information on your patient, right at your secondary or even before secondary, but more so once you have gotten the patient's ABCs dealt with, you have gotten the history, you have gotten the vital signs, you need to call into the receiving facility, let them know what the condition you are coming in with your patient, and so that they can be prepared to deal with what they have to deal with when you reach there. It's very important. And we say it is documentation is important, very critical for these patients, especially in sexual assault cases. These cases are legal cases. You can be called to go to court, and so what is written is what gonna be used to assess what you have done in that case. And remember, very important, scene preservation. You are there to provide care for the patient, both physical care and psychological care, but also remember you are trying to preserve that scene for the persons who the police will be coming to investigate. So be mindful of it. Try to preserve evidence as best as possible. Any clothing from the patient, you put them in paper bags, which will help to preserve the evidence. It won't break down as if you would put them in plastic bags. They always encourage the patient not to try to clean up himself, not to urinate, not to pass any stool, not to wash out their mouth, because these will get rid of evidence. So in the end, if they insist, then you cannot force them not to, but try to encourage them not to. And also, all interventions, you have to make note of them. It's very important. As it relates to emergency medical care for these specific gynecological emergencies, you will just take that into consideration apart from the general care that you would carry out for your patient assessment. So maintain the patient's privacy and modesty as much as possible. We say that they're gonna be concerned about their, their modesty and their privacy. So try to treat them in the ambulance, or if you need to treat them out in the open, try to have some sheet to at least give them some form of privacy. Treating for shock and transportation should be prioritized. Once you recognize that they have a life-threatening situation, treat them for shock and give them that supportive care, and recognize that you need to move from the scene within that 10 minutes. Use sanitary pads on the external genitalia to absorb the blood. and we say you will never pack anything inside the vagina, not even no tampon. If they already have tampon in place, then you can leave it in place, but you're not gonna pack, insert one
Place the
or pack
patient on the
anything
left
inside the
side
vagina.
so that she will be facing you instead of the wall of the ambulance. Okay.
That's a question, Miss Michelle. Okay.
No, sir.
So what you recognize is that, okay. So the ambulance most ambulance by default has the stretcher on the left side facing it. So by right, once you place the patient on their left side, then they will be facing you, the caregiver, on the right side. And that's what you want, because you don't want to have your patient back turned to you. You cannot assess a patient with their back to you. So that's what they are saying. You will always place them in that position that they are facing you. So in the odd case where you have the stretcher rack being on the right side and you're on the left side, then you would place them the other way. But most ambulances, proper ambulance, are designed that way, that they will by default have the stretcher on the left side. So it's very important that you have your patient facing you. A part of another, as we continue with emergency medical care for these patients having gynecological emergencies, you're going to treat any external laceration, abrasion, and tear with sterile compresses. Again, we say don't pack anything inside the vagina. Just cover it with your diaper type dressing to control the bleeding, and note the amount of soap and pads. Bring them in so that they can be assessed further. You can have an idea of the amount of blood loss. Consider the possibility of pregnancy. Be prepared for a possible miscarriage. And again, we say all persons of childbearing age assume that they are possibly pregnant, and make sure you ask relevant questions. And one main question is when last they had their menstrual cycle, because that will give you an idea of what can be happening. So we have to act professional. Very important that we act very professional in these cases and be non-judgmental, be empathic, be reassuring to this patient. Very important that we consider the psychological stress that they are going through, especially when we think about sexual assault cases. Be mindful of that, and always, be that advocate for your patient. When it comes down to assessment of pelvic inflammatory disease, they are going to be exhibiting lower abdominal pain. Again, we say we cannot be sure that it's PID, but we can have our suspicion based on the history. Again, it is treat what is presented. So patient will generally walk doubled over and guard the abdomen, place the patient in position of comfort, provide transport to an appropriate facility. Again, it can be other conditions that's happening, but we are having our suspicion based on the history and presentation also, but it is to treat the patient according to what is presented to you. You can have a case of ruptured ovarian cyst, and we say it is when this cyst that is on the ovary rupture. Sudden onset of severe lower abdominal pain may be present. Unilateral pain may radiate from abdomen to back. So unilateral means it's going to start on one side, and more than likely it is side where the ovary is having the cyst, which ovary is having the cyst. It's going to start from that side and radiate from the abdomen to the back. And we know that it's referred pain because of the pleural lining and the nerves ending that are connected. There may be some vaginal bleeding. Again, we're not sure which is causing the bleed, so treat them accordingly. The worst case, one of the most serious gynecological emergency is the ectopic pregnancy. Patient usually presents with signs of hypovolemic shock because we can have severe loss of blood in ectopic pregnancy. The fallopian tube rupture, that area is highly vascular. You can have severe bleeding. Monitor the patient for impending shock, including orthostatic vital signs. So this is where you're going to, you want to know if there's high orthostatic hypoperfusion. So the patient vital signs should be assessed while they are in the supine position, and then you assess it once they are sitting up or standing. Standing up more likely, and you're gonna compare it. So if you have a reduction in the systolic blood pressure of more than 20, or a reduction in the diastolic blood pressure of more than 10, then we are saying that we have orthostatic hypotension. Also, the pulse rate, if it's increasing by more than 20 beats per minute in the first 3 minutes, then that's also an indication of orthostatic hypotension. The ruptured ectopic pregnancy is a true medical emergency. This is a life-threatening situation. This is not something you want to play with. So once you recognize it, then you need to package that patient, give them that care, and as an advance, then you recognize if they're having that high potential, then you need to ensure that you have that fluid resuscitation going and try to maintain their systolic above 90 millimeters of mercury. Again, not wanting to overload them, and transport the patient rapidly to the closest appropriate facility. So at least you need to get 2 IV line in place, large bore as possible, and get that fluid going. That's the most you can do. Supportive care and ventilate if needed, oxygenation, treat them for shock. With vaginal bleeding, patient may experience amenorrhea or heavy vaginal bleeding. Always assume that bleeding during the first or second trimester of pregnancy might indicate a spontaneous abortion or miscarriage. Also, we say it can be from ectopic pregnancy. Third trimester bleeding is a serious emergency. We mentioned that it can be from the placenta abruptia or previa. You will see that more in your obstetrical emergencies. Inquire about the onset of symptoms. So that will give you an idea of what is causing this vaginal bleed. But again, we say our focus is not so much on what is causing it, is to treat what is presented and give that patient the supportive care and take them to where they can get the definitive care. So patients with abdominal trauma can present with severe bleeding, pain, and hypovolemic shock. So that is why you're going to focus on treating them for the shock, what they're experiencing, as against trying to search and find what is causing it. So when you look at specific emergencies as it relates to gynecological emergencies, we see that it can have third trimester bleeding is a serious emergency. Inquire about the symptoms, onset of symptoms. Patients with abdominal trauma can present with severe bleeding and hypotension, hypovolemic shock. So that's our concern once they are having these gynecological emergencies. Once bleeding is involved, it is a possibility that they can go into shock and treat them accordingly. Again, some of the cases will not be life-threatening. You provide their supportive care. Sexual assault is one of the instances you will be called to for these patients, and we say that it can take many forms. Again, most common is rape. Whenever possible, a female rape victim should be given the option of being treated by a female AEMT. If that is not possible, then you can ask the patient if they have a female friend they want to be there with them. And we say, as a last resort, you can call for a female police officer to be there. Professionalism, tact, kindness, and sensitivity are of paramount importance. Remember, these patients would have gone through a incident that has left them traumatized. They need psychological care. So we are there to provide a physical care, but you must also remember that psychological care is a part of the care you need to give as an advocate for your patient. Limit any physical exam to a brief survey for life-threatening injuries. So if you do not have to examine the vagina physically, you just do your rest of checks. And most cases, as I said, if it's a bleeding, the patient would have started the initial care of having a sanitary pad there or napkin. You just ask about how many soaked pads they had before, and you can bring them in with you. But it's all about being sensitive to that patient and give them that care that will help them through the situation. And again, these are legal cases that you will call to. So preserving evidence is important also, but it's not going to take precedence over what you have to do. But in doing what you need to do, you try to as best preserve evidence. First issue is the medical treatment of the patient, as I said. Second issue is your psychological care, and have a responsibility to preserve evidence, follow protocols if patients refuse transport altogether. So the patient, once they are competent, once you deem them competent, then they have a right to refuse transport. They have a right to refuse even care. But you must inform them. It must be an informed refusal. So they must tell them the benefit of the care that you were planning to give them. You must tell them of the danger, the risk involved in not getting this care. If you tell them all of that and they still insist and you deem them to be competent, then they have a right to that refusal. You follow your protocol. You should have a refusal form. You get it signed by them and get a witness to witness it, and that will cover you. But also encourage them that if they feel the need to call back for the ambulance, don't feel any way that they should not call. They should always call and try to encourage them to get someone to be there with them in case the situation reoccur. Now recognize that in these sexual assault rape cases, the perpetrators can use date rape drugs to facilitate their intent. And so if drugs are still in the patient system during your assessment, hypotension, bradycardia, difficulty breathing, seizures and coma, and even death may occur. So recognize that this is possible. And you also have this sexual practice where they have what you call fisting. So you might be called to a scene where person's organ are ruptured because of fisting, and this is a procedure where they insert the whole hand into the vagina or the anus. And they have cases where they have sexual practices where they insert live animals. Also in these areas, they will use fish, snake, all sort of live animals. So they will call you when they might insert one of these animal and the animal don't come back out. So you'll be called, and they will have objects inside the vagina, and they try to remove them, and they create a vacuum, and they are causing tear, and so they will call you at that point. Again, once there's anything impaled, you will not attempt to remove it, because you will cause the same damage. That will have to be done under a controlled environment in definitive care. What you need to do is to stabilize it, give the supportive care as usual, manage their ABCs, and take them in for definitive care. Again, always be mindful of the patient's privacy as best as possible, supporting, not be non judgmental. Don't judge them because of their practices. Just be mindful that you're there as a professional, you act accordingly. And this is the end of this chapter on gynecological emergencies. Any questions?